All right. So let's start with the discussion of the mini test that you had, beta. I hope you guys are there. Chalo, let's start with the first question. So the first question was, the breast clinic in the surgery department has admitted 4 patients of carcinoma breast for management. Which of the following patients are not the right candidate? So which of the following are not right candidates for radiotherapy? Okay, beta. So whoever are there in the chat, what did you guys answer? All those who are there, just say hi so that I know who's there in the chat. Sorry, we started just we started an hour late. I hope you are here. Chalo, let's start discussing. I hope you guys will join in between. Okay. All right. So we had this patient, these 4 patients are there. So let's look at the options first. The question is asking which of the following is not the right candidate for radiotherapy. Whoever is joined, just say hi so that you know, so that I know who's there. Okay. All right. A 34-year-old patient who post right modified radical mastectomy with a level 2 axial lymph node dissection was done. All the axial lymph nodes were negative on the histopathological examination for T2N0M0. So basically, this is a node negative condition. Okay, T2. T2 means what is the size? It is less than 5 centimeter. So this is what? This is not qualifying the indication for radiotherapy. We'll be reading what are the indications, but this is not qualifying the indication for radiotherapy. A 39-year-old female post breast conservation surgery. So we know that once BCS is done, you have to definitely give radiotherapy. So this is an indication. A 42-year-old post mastectomy with lymphovascular invasion present on histopathological. So if you have lymphovascular invasion, that again qualifies as an indication for radiotherapy. And last is a 45-year-old female who underwent modified radical mastectomy for T4A N1M0 tumor. So first of all, this is LABC. And also remember, this is a node positive. So whenever you have node positive, that also qualifies as it qualifies as what? It qualifies as a indication for radiotherapy. Okay, beta? So yeah, answer for this is option number A. This is not an indication for radiotherapy. Now, we see from here discussion that we have had earlier that T2 is what? From 2 to 5 centimeters. So it is less than 5 centimeters basically. More than 5 centimeters is what we classify as an indication for radiotherapy. So what all are the indications? Patients who are having locally advanced breast cancer, those who are having lymph node positive, those patients who have undergone breast conservation surgery, those patients where mastectomy is done, and what else do you have? If the tumor size is more than 5 centimeter, if there is skin or chest wall involvement, if there is lymphovascular invasion, like it was mentioned in one of our options, and if the tumor is grade 3. These are all the indications for adjuvant radiotherapy in breast cancer. Okay, this is a very, very important area, beta. You have a lot of questions that are coming from this area. That's why this question was included in the test. Okay, beta? Okay. Now, we have discussed for radiotherapy. Let's quickly discuss the indications for chemotherapy as well. So let's talk about the neoadjuvant chemotherapy. So what are the indications? If it's a locally advanced breast cancer, that is stage 3A and 3B, 3C, stage 3 basically. Triple negative breast cancers, TNBC. If you have HER2 new positive breast cancer, that is also an indication for neoadjuvant chemotherapy. And obviously, if a patient is wanting to have a breast conservation surgery, when you downsize the tumor, that is what you do. You downsize it giving NACT, and that's when you can prefer going for breast conservation surgery. Okay, beta? Okay. All those who are there in the chat, just say hi so that I know who's there in the chat. Okay? All right. Indications for adjuvant chemotherapy. This is what is there in the 20th edition of Bain and Love, beta. All the invasive carcinomas which are more than 1 centimeter in diameter. Tumors which are more than 0.5 centimeter with what? Poor prognostic factors. What are the poor prognostic factors that need to be considered? If there is presence of lymphovascular invasion, if the tumor is of high grade, if it is HER2 new positive, if it is having a triple negative breast phenotype. So if it is triple negative, and also if it is node positive. These are the indications for adjuvant chemotherapy. Okay, beta. Chalo. Next question. This is a very good question, beta. Let's discuss this. A 50-year-old man presents 12 hours after thyroidectomy with stridor. Thyroidectomy हुई थी 12 hours ago, and now he is presented with stridor and severe respiratory distress. Neck swelling is minimal. The patient is unable to be intubated. Which of the following is the next best step to secure the airway? क्या आंसर होगा बेटा? नेक्स्ट पूछा है इसमें. अब ये थोड़ा सा कंट्रोवर्शियल क्वेश्चन है. लेट अस डिस्कस व्हाई इट इज अ कंट्रोवर्शियल क्वेश्चन. What did you guys answer? Okay, those who have not attempted the test, can you answer? What is the answer for this question? Yeah, hi Pooja, the answer is C. Okay, so you're right. What will you do next? You will not go for needle cricothyroidotomy here. These were the older versions. 11th edition of ATLS says that you have to directly go. This is the scenario which we call as can't intubate, can't oxygenate. C को scenario में आपको. So what are you supposed to do? The next best step that you're supposed to do in such cases is to gain a better airway. That is by the means of emergency cricothyroidotomy. You don't go for needle because needle का आप कितनी देर तक रख सकते हो? 30-40 minutes, but you don't know. You have to go in and reoperate the patient. So therefore, in such scenarios, you'll have to go for emergency cricothyroidotomy. That is what is the best option that you should be answering here. This is as per the 11th edition of ATLS. Okay, तो ये आपको पता होना चाहिए. बेटा री-एक्सप्लोर द नेक इन ओटी इज नॉट द नेक्स्ट बेस्ट स्टेप. ध्यान रखना है इसको. इमीडिएटली ओटी में तो नहीं ले जा पाओगे. पहले क्या करना है? एयरवे. अच्छा, एक और इससे पहले if there was another option that was to loosen the sutures. अगर sutures आपको काट के रिलैक्स करना होता नेक को, that was a better option so that you could ease off the hematoma. That would have been a better option अगर वो होता तो. But it is not there. Then तो पहले आपको hematoma अगर है, इसमें mention नहीं है, पर it could be a deep-seated hematoma. जरूरी नहीं है कि अगर swelling obvious है, that is when there is it could be a deep-seated hematoma also. So you have to definitely loosen up the sutures, and then next step is obviously will be the airway. In airway, you have to go for emergency cricothyroidotomy. Okay, got it? Okay, you're right, Pooja. You're right, Arun. So answer is option number C. Next, what is this? क्या है? Okay, so the question was saying that the accompanying video shows a procedure being performed for an anorectal condition. Okay, which of the following statements are true? First, so basically 4 statements are given. You have to identify what all statements are true. Number 1, flattest passage through external opening indicates rectal internal opening. Goodsall's rule is used to predict the location of external opening. Ligation of intersphincteric tract, that is LIFT, is a sphincter saving procedure. And short tau inversion recovery sequencing highlights paths without contrast. Beta, it is not Thiersch wiring. ध्यान से देखो क्या हो रहा है. What is happening? There is a probe that is being inserted into the fistula. It is not Thiersch wiring. Beta, थोड़ा ध्यान से देखो वीडियो को. Yeah, so there is a probing that is being done. So it is not clear whether it is LIFT or not, because LIFT में तो आपको क्या करना पड़ेगा? इंटरस्फिंक्टरिक प्लेन दिखाएंगे, सब कुछ दिखाएंगे, लाइगेशन होते हुए दिखाएंगे. इसमें सिर्फ क्या दिख रहा है कि एक प्रोब हम इंसर्ट कर रहे हैं एक्सटर्नल ओपनिंग से, which is guiding you towards the internal opening of the fistula. Is it clear? समझ में आ रहा है बेटा कि वीडियो क्या दिखा रहा है आपको? पहले तो ये समझो, तभी तो आप आंसर तक पहुंचोगे. फर्स्ट यू हैव टू अंडरस्टैंड व्हाट इट इज शोइंग. So it is showing the probing of the anal fistulas. ठीक है, चलो अब आगे बढ़ते हैं. Let's discuss this question. Okay, Dhanush, what are you saying? It's C. This is for this question. So what are you saying? Option number 1, 3, and 4. Okay, so you're right. Let's discuss. So what is the statement 1 saying? Flattest passage to the external opening indicates the rectal internal opening. Obviously, if there is a fistula and there is a connection between the rectum, that is when flatus is going to be coming out from the external opening. So this is a true statement, right? Goodsall's rule is used to predict the location of external opening. This is not true. What do we predict with the Goodsall's rule? External opening to dikh rahi hoti hai. You predict the opening on the internal side. So internal opening is predicted with Goodsall's rule, not the external opening. So you predict not the external opening, you predict the internal opening with the Goodsall's rule. So the answer is B. That is incorrect. So 2 is incorrect. Ligation of intersphincteric tract is a sphincter saving procedure. Absolutely true. So what you're doing, basically you're going via the intersphincteric plane. Though transsphincteric fistulas के लिए basically use होता है. So we go via the intersphincteric plane. We identify the fistulous tract. उसको हम ligate करते हैं. Suppose this is the fistulous tract. Ligate किया उसको, बीच में से उसको काटा, transact किया, and that is when this is how the ligation of intersphincteric fistulous tract is done. ठीक है? Okay. Then we talk about short tau inversion recovery sequencing highlights pus without contrast. This is very true statement. So how do we remember STIR? It suppresses the tissue and it enhances what? The basically reactive. So edema, pus, fluid, ये सब आपको कौन दिखाता है? It shows the STIR sequence. आपको stirred sequence में देखने को मिलता है. So what is true? Statement 1 is true, 2 is not true, the 3 is true, and 1, 3, and 4, which is the option 1, 3, 4. So option number C is true. Yeah. So this is the answer. Up, let's discuss some important concepts which are related to this question. Beta, the first thing that we'll discuss is the Goodsall's rule. What does Goodsall's rule tell you? It tells you about the internal opening, not the external opening. It tells you about the internal opening. So these are the discussion notes that we have in our app. This is how we have discussed it in the modules that are there. If you are using our app, you'll be seeing this modules very frequently. So let's talk about the first condition. If the external opening of the fistula is anterior, matlab it is here. If it is in the anterior above the line that is there, anal verge, within 3 centimeters of the anal verge, then the internal opening is going to open where? It is going to open into the anterior wall of the anal canal. Anterior to the anal verge is the opening, but where? Within the 3 centimeter. 3 centimeter के अंदर है, so it will open where? So you can see here, which are the ones we are showing here, बेटा ये वाली openings की बात हो रही है. Within 3 centimeters अगर हैं, तो कहाँ खुलेंगी? They'll open where? In the anterior wall. Okay, but if you have any other ones, इसके अलावा कोई भी openings हैं, where are they going to open? They are going to open in the midline posteriorly. So it is present here, it is present here, it is present here, it is present here, it is present here. Everything is going to open. If it is within the 3 centimeter, then it is going to open in the anterior wall. Where? If it is in the anterior part, then it is going to open in the anterior part. All others are going to open where? In the midline posteriorly. This is what you need to remember. Anterior opening mein, there is an exception. If it is away, if it's a far off, so it's a long anterior fistula, if it is beyond 3 centimeters. So when you have a long anterior fistula, if the external opening is more than 3 centimeters from the anal verge, that will also follow a tract with opening in the posterior midline. So curved tract opening where? In the posterior midline of the anal canal. Got it, beta? This is extremely important. Goodsall's rule you have to understand carefully. There can be conceptual questions coming from Goodsall's rule. It's a very, very important thing for the examination. Okay. All right. What are these sphincter preserving procedures? ये आपको नाम पता होना चाहिए at least. LIFT we have just discussed, ligation of the intersphincteric fistulous tract. We basically ligate and divide the tract. Where? In the intersphincteric plane. Basically used for which fistula? Transsphincteric fistula. This is what is most commonly going to be asked in the exams. So आपको याद रखना है. Then loose chiton जो होता है बेटा, that is what is also sphincter preserving type. दूसरा चिटॉन नहीं, कटिंग चिटॉन की बात नहीं हो रही है, लूज चिटॉन की बात हो रही है. ठीक है. In high complex fistula and Crohn's disease, it is one that is going to preserve the sphincter. Then your advancement flaps, endorectal or anocutaneous flaps, these are also sphincter preserving. In the recent INI-CT also, they've asked a question from this. This is a very important topic from where there is a likelihood of the question being asked. Okay, so therefore, this is something you should be reading very carefully. Internal opening gets closed with a mucosal flap. Where is it used? In high fistulas or recurrent fistulas. Fibrin glue injection, कुछ नहीं कर रहे आप, sealant डाल रहे हो, that is what you are doing, that will fill the tract. It is basically for simple fistulas, but the chances of recurrences are also high because obviously ना आप वो tract में आपने क्या permanent repair तो किया नहीं है, just put in a biological sealant, so the recurrence chances are high. So therefore use only for simple fistulas. Anal fistula plug or bioprosthetic plug, that is going to obstruct or occlude the tract. This is also sphincter preserving. Then the VAAFT, what is this VAFT? video assisted anal fistula treatment. So basically, you'll have an endoscopic visualization, which will be following with the tract ablation, complex fistulas. Then we also use a laser, which we call, the procedure is called as the fistula laser closure, FILAC, okay? Which is the laser, radial laser. That is where we use it in transsphincteric fistulas, right? And the last one is OTSC, that is over the scope clip. Basically, your clip is going to close the internal opening. तो ये सारे नाम आपको याद होने चाहिए. They can be asked directly, which among the following is not a sphincter preserving procedure, and you'll have to choose one of them. These are the ones that are going to preserve the sphincter. ठीक है? Okay. चलो, we have to talk about the steps of LIFT also, बेटा, ताकि आपको पता रहे कि होता क्या है. So once the examination is done under anesthesia, you identify the external and the internal openings of the fistula. We are doing the step that was shown in the video. We probe the fistula strap. क्या probe किया, उसके बाद क्या हमने intersphincteric incision लगाया. Sphincters को touch नहीं किया. Sphincters के बीच का plane हमने चुना है. We have chosen the intersphincteric plane. We basically then go via the, suppose ये आपके sphincters हैं, बीच का plane हमने चुना, यहाँ से हम dissect करते हुए गए, हमको fistula tract मिला, external opening, internal opening. Suppose this is what the tract is going like, ऐसे tract जा रहा है, तो इसको हमने, suppose ये tract है, तो we have dissected off, अब tract दिख रहा है, तो हमने tract के पीछे से एक सूचर नीचे लिया, एक सूचर ऊपर लिया, दोनों को ligate कर दिया, बीच में से tract को transact कर दिया. This is what is known as, so basically we ligate the tract on both the side, that is double ligation. We divide or transact the tract between the ligatures. Also, external tract को आपने curate off कर दिया, and we close the intersphincteric incision. So this is how LIFT is performed. ठीक है? Okay. So let's talk a little about the short tau inversion recovery sequence. What is basically done? Fat is suppressed. ये आपको पता होना चाहिए. So fat gets suppressed, basically suppresses the fat signal and enhances the fluid. Fluid is made bright. So what is pus? Basically, pus is going to appear hyper intense or bright. Do you need a contrast insert sequence? No. Without the contrast itself, it can detect the fluid. So what all does it detect? It detects the edema, pus, abscesses, inflammation, fistula tract. Which is the most common investigation in the investigation of choice of fistula? It is going to be MRI fistulogram. ठीक है बेटा? Okay. अब देखना क्या है इसमें, कैसे याद रखते हैं इसको? It's simple. S with suppression of the fat, T2 based inversion recovery. I, that means it is going to show what? Infection and inflammation as bright. What is it going to reveal? It is going to reveal pus, edema, abscess, and fistula tract without the contrast. Okay? All right. Next question. ये क्या है बेटा? What did you mark for this? इसका बहुत सिंपल सा तरीका होता है. I hope you guys know how to answer this kind of questions. What is the X-ray? Is it an anterior-posterior or a lateral X-ray? क्या है बेटा? What is this? Yeah, it's a foreign body in the esophagus. Yeah, okay, Pooja, you're right. So basically what is happening here, an infant who was playing without supervision is brought to the emergency department with the difficulty in swallowing that has started few hours ago. Okay, problem क्या है? Difficulty in swallowing. Breathing में कोई problem नहीं है, swallowing में difficulty है. A radiograph is obtained. What is the diagnosis? It's the AP view. You're right. Okay, this is the AP view. So basically, अब समझो बेटा, एक छोटा सा simple सा मैं आपको coin के साथ समझाता हूँ कि क्या हो रहा है. Okay. So see, suppose this is the coin that the child was playing with, and the X-ray is what? Anterior-posterior X-ray. We know one concept that trachea has what? The deficiency of the tracheal rings is on the dorsal of the posterior aspect. So how is the coin going to go? Can the coin go like this in trachea? En fast जा सकता है क्या? जैसा कि ऐसे दिख रहा है इसमें. Can it go en fast? No, it is not going to go en fast because it is not getting the space only. Trachea में coin कैसे जा सकता है? ऐसे. This is how the coin is going to go. So I'll show it to you. This is how it is going to go. It is not going to go like this in the trachea. ऐसे जा पाएगा, ऐसे तो जा नहीं पाएगा. Tracheal ring रोक देंगे उसको. So this is the only way it can go into the trachea. ऐसे जाएगा तो anteriorly क्या दिखेगा? Anteriorly केवल edge दिखेगा. Lateral view में en fast दिखेगा अपने को किसमें? If it is inside the trachea. Esophagus में क्योंकि space pliable है, तो this is how it is going to go in the esophagus. Okay, this is the basic concept of these questions. If you know, you'll be able to answer, right? So in esophagus, when you have AP X-ray, what are you going to get? NFAS of the full circular disc, whereas on the lateral X-ray, you'll get only a thin edge. Whereas if you talk about trachea, and trachea, if the coin is there, NFAS जब लोगे सामने AP view लोगे तो क्या दिखेगा? AP view में केवल edge दिखेगी. Lateral view में is where you'll see the entire coin. That is what we call as the NFAS appearance. ठीक है? Okay. अब बेटा foreign body esophagus again is an important topic. उसमें जल्दी से डिस्कस कर लेते हैं क्या क्या चीजें होती हैं. ठीक है? Okay, so children obviously have more likelihood of getting a foreign body in the esophagus as compared to the adults. Adults में कहाँ हो सकता है? When they have swallowing difficulties, especially in cases of dementia, mental health disorders, or alcohol abuse. Common sites we know wherever there are esophageal constrictions, that's where the foreign body can lodge. So in the cricopharyngeus or pyriform fossa, in the mid-esophagus, where there is crossing of the aorta or the left mainstem bronchus, and at the esophagogastric junction, which are the common foreign bodies that can lodge. It could be fish bones, pork, chicken, or even dentures in the elderly who are edentulous. Best investigation, remember, it is going to be CT scan. Chest X-ray जब भी करते हैं, the first investigation, AP or lateral view देखोगे. I've just explained to you how you have to detect esophageal foreign body and how you should be detecting the tracheal foreign body. That's what I told you. Whenever the tracheal foreign bodies go, NFAS view कहाँ से दिखेगा आपको? Laterally NFAS view दिखेगा. मतलब the entire coin is going to be visible when you have a lateral X-ray about the tracheal foreign body. Okay. If the foreign body is, how do you manage basically? If it is symptomatic and at C6, the treatment of choice is you'll be going for a flexible endoscopy. You'll be using forceps, net, baskets, or balloon. But remember, balloon use करेंगे तो distally inflate करके उसको ऊपर की तरफ खींचते हैं. The key point that can be asked in the examination: what if it's a pointy or a sharp object? जब भी शार्प ऑब्जेक्ट का रिट्रीवल करते हैं तो जो पॉइंटेड पॉइंट होता है वो डिस्टली रखते हैं उसको. कभी भी जब भी निकालेंगे उसको तो वील पुल इट आउट इन द वे दैट द पॉइंटी एंड इज पॉइंटिंग डिस्टली, नॉट टुवर्ड्स यू वेयर यू आर पुलिंग इट. ओके, सो दैट इज व्हाट इज वन कांसेप्ट. Then, if it is asymptomatic and beyond C6, we expect that it is going to pass down. Okay, it is going to be pushed down and it is going to pass it. Then pass out of the body. Then button batteries. The button batteries, we know we cannot leave it there. It has to be removed endoscopically, irrespective of the site. Why? It can cause direct electrical burn, or obviously we have read about it. It causes liquefactor necrosis, alkaline. Okay, beta. And what is it that we need to know? That if it is failing, you'll have to go for open surgery if it is a button battery. Okay. So these are the basic concepts that you were supposed to know, right? Okay. I समझ में. चलो, next question. What did you mark for this question? Okay, or if you have not marked, what do you think is the answer for this question? Kamlesh is saying it is D. Okay. What else? Anybody else? Chalo beta. Okay, let's discuss this question. So an elderly T3, if the question says child respiratory distress and the foreign body is in trachea, of course you'll have to get it out, beta. Bronchoscopy आपको करनी पड़ेगी उसमें. You'll have to take it out. That's what you have to do. If it is in the trachea, it's an emergency. Yeah, it has to be taken out. Yeah. An elderly male. Okay, let's discuss this question. I hope you got, Pooja, what's your answer that you were expecting? Best management is you have to go for bronchoscopy in that. Yeah. An elderly male man presents with a malignant lesion of the penis as shown in the image. He is staged as T3 carcinoma penis and has no clinically palpable inguinal lymph nodes. What is the most appropriate management? अब क्या देखा बेटा इसमें? आपने देखा कि ऑप्शंस क्या क्या है पहले तो ये देखो, एवरीथिंग इज मेंशनिंग पार्शियल पिनेक्टोमी, सो इज अ डाउट वेदर कि उसमें 2 सेंटीमीटर का स्टंप छूट रहा है कि नहीं छूट रहा, कितना मार्जिन छोड़ना है. सो आइडियली व्हाट इज द मार्जिन दैट यू नीड, 2 सेंटीमीटर ऑफ स्टंप शुड बी लेफ्ट बिहाइंड, एंड एज पर द लेटेस्ट गाइडलाइन 5 mm ऑफ टिश्यू इज द मार्जिन दैट यू आर सपोज टू लीव. सपोज ट्यूमर यहाँ पे तो 5 mm का आपको छोड़ के फिर 2 सेंटीमीटर का स्टंप आप कैलकुलेट करते हो, ठीक है. दिस इज व्हाट यू आर सपोज टू नो. ओके, अब इसमें क्या बोल रहा है कि नोड नेगेटिव है, देयर इज नो क्लिनिकली palpable inguinal lymph node, then what are you supposed to do? You will have to at least do a sentinel lymph node biopsy, that is extremely important, ठीक है, because we know there is in penile cancer, this is what you have to do. If it's node negative, SLNB has to be done. So what is the sentinel node in cases of penile carcinoma? It is the superficial group of inguinal lymph nodes. So therefore the answer is going to be partial penectomy with the superficial inguinal lymph node dissection. ठीक है बेटा? Okay. What is this? ये हम पढ़ चुके हैं बेटा. I discussed sutures at length. Okay, so basically, this is a PDS suture. We have already discussed that PDS suture is a synthetic what? It's a monofilament suture. So we have already discussed this thing that it is a synthetic monofilament kind of suture, and that is what is your answer here. You should be knowing this about PDS. ठीक है? तो क्या क्या चीजें पता होनी चाहिए पीडीएस के बारे में, दैट इट इज अ सिंथेटिक absorbable monofilament kind of suture. It is retained for a long duration, 6 weeks, and thereafter gradual loss will begin. Approximately, the entire complete absorption happens in 180 days. We can say 180 to 210 days, roughly 6 months. Okay, all right. What did you answer for this? A, no, beta, it's a monofilament. That is what we had discussed. पूरा suture अच्छे से discuss किए थे आपके साथ, right? We had discussed this sutures in depth. It's a monofilament suture, right? Tissue reaction is minimal. Next. A and similar statements, polyfilament and braided are the same. Yes, polyfilament and braided are the same, but braided sutures are usually other polyfilament sutures, okay? So A and C is the same. That's why that also can be used as a concept to rule out A and C, okay? Anyway, you should be knowing that PDS is a monofilament synthetic absorbable suture, okay? Yeah, this is what we had discussed in our discussions before also, that there are characteristic bronchial changes that are present. You are having a characteristic bird beaking appearance. And do not get confused with weight loss. Look at the age of the patient and look at the characteristic complication that happens, that is aspiration pneumonia. I've discussed this at length with you. Therefore, the first investigation of choice is the diagnosis of achalasia cardia. The investigation of choice, the first one that you're going to do, the preferred investigation is manometry. This is going to be done to rule out malignancy. So definitely this also will be done, but not as the preferred investigation. This will be done to rule out malignancy. What are we trying to rule out? We are trying to rule out pseudo-achalasias, right? So this has already been discussed. All of you should be noting it, right? Yeah, Pitanshu. Okay, good. What is this? Yeah, Arun, you're right. ये क्या है बेटा? What is this? ये क्या था? Yeah, Chicago classification. Chicago 4.0 classification is used. Good. What is the answer to this question? Question number 8. B, also neurotensin. Yeah, okay. So this is a characteristic presentation of fibrolaminar hepatocellular carcinoma. क्या क्या clues हैं बेटा? Young age में हो रहा है, females में है, elevated neurotensin level there, which is pretty much diagnostic. There is no history of cirrhosis. It's happening in a normal liver. and there is a normal AFP. Tumor is well encapsulated as well as demarcated. This is a presentation of a fibrolamellar HCC. Also, histopath slides are giving you the characteristic fibrous bands that are visible. This is the diagnosis of fibrolamellar hepatocellular carcinoma. Let's look at the key features that will differentiate. So conventional HCC age group is generally 50 to 70 years. When you talk about the fibrolamellar variant, it happens in the younger age group. I told you it does not happen in a cirrhotic liver. It is usually in the absence of cirrhosis. Alpha fetoprotein is going to be normal. Neurotensin levels will be elevated in these patients. Usually, it's going to be a solitary lesion. It is going to be encapsulated and well circumscribed. वेरी इंपॉर्टेंट, जब आप हिस्टोपैथ स्लाइड देखोगे तो लैमेलर फाइब्रोसिस आपको मिलेगा. Prognosis is comparatively better as compared to the conventional HCC if it is resected, right? Okay, what is this question? Yeah. चलो ये बताओ. Pooja is saying it is B. Dhanush is saying it is B. Dhanush saying fibroadenoma, and yeah, okay. So you're right, basically. So basically, we have a 38-year-old woman who presents with the cyclical mastalgia and palpable mobile breast lump. Okay. So a mammography shows well-defined cyst without super suspicious any microcalcifications. Core biopsy reveals cyst with duct ectasia and fibrous stroma without any proliferation or atypia. So this is non-proliferative kind of lesion. It's a non-proliferative breast disorder. Which of the following is most accurate? Non-proliferative breast disorders are associated with significantly increased risk of lifetime breast cancer. No, they are not associated with an increased risk of breast cancer. The condition accounts for majority, absolutely true, and carries no increased cancer risk. This is a true statement. The presence of duct ectasia implies a pre-malignant process. No, duct ectasia is a benign condition and it does not require close oncological survey. Oh, this is wrong. Sorry, but this is not true. This is a wrong statement. Okay, so this is incorrect. And fibrocystic disease represents a single uniform. No, it's not a single uniform. It's a spectrum of disorders that you're looking at. So the answer is option number B. Okay. So what are the non-proliferative types that you already know? Cyst, fibrosis, apocrine metaplasia, and mild duct ectasias. Okay, there is no increased risk of cancer in these conditions. If you have proliferation but there is no atypia, what are you talking about? You're talking about the lesions like hyperplasia, sclerosing adenosis, papillomas, and radial scar. They have 1.5 to 2 times risk of malignancy. Proliferation, when it happens with atypia, are your ADH, atypical ductal hyperplasia, and lobular hyperplasia. They definitely have a higher risk of conversion. Okay, Chal, next. What is this? Straightforward, a bit easy question. Hai? Yeah, it's a direct hernia. Okay. What are you going to do, beta, in direct hernia? Yeah. So A patient has been diagnosed with inguinal hernia that is situated. Yeah, okay, you're right. Arun, you're right. Dhanush, you're right. So it is situated where on the medial side of the inferior epigastric. Medial to the inferior epigastric is direct, lateral is indirect. Okay, medial comes from the Hasselbalch triangle. What is the correct diagnosis and recommended surgical management? So whenever you have this hernia, and what are the options that you have? You have the best option, that is to do a Lichtenstein tension-free mesh hernioplasty. So mesh hernioplasties are standard now. So direct inguinal hernia will be, which is the option which is giving you. So it's a direct hernia. Indirect gets ruled out. Bassinis is not done. Bassinis is not done. Obviously, it's indirect, and this is what is the answer. So we do a Lichtenstein mesh technique repair. So the answer is option number D. Okay. Next. When we're talking about the direct and indirect hernia, let's quickly differentiate between both of them. So we have understood this fact that relationship to the inferior epigastric vessel, direct hernia is going to be medial and indirect hernia is going to be lateral. Origin of direct hernia comes from the Hasselbalch triangle, whereas indirect hernia comes from the deep inguinal ring roughly. Cause of direct inguinal hernia is the weakness of the posterior wall. It's generally an acquired condition, whereas indirect hernia is because of the patent processus vaginalis. That's why it can reach up till the scrotum. Direct hernia will not reach up till the scrotum. Age, direct hernia is usually in the older age group, and the indirect hernia generally occur in the younger population. Neck is going to be narrow where in cases of indirect hernia. Therefore, the chances of strangulation are also going to be more in cases of indirect hernia. What is this, beta? Kya dikh raha hai? Okay. Question number 11. What is this? Okay, so let's discuss this question. A duplex ultrasound video of the groin is obtained in the transverse plane at the level of the SFJ, okay, saphenofemoral junction. Based on the anatomical structures demonstrated in the video, which of the following is not part of the characteristic transverse appearance at this level? So what is basically seen, this is the level of SFJ. So what all do you see here? You see the common femoral artery, common femoral vein, and great saphenous vein. What is this called as? This is called as the Mickey Mouse appearance. Mickey Mouse appearance. What is not there in this appearance? Superficial femoral artery is not there. Okay. So this is what you are supposed to know, that SFJ, basically you have these three important structures which are generally seen, which is known as the Mickey Mouse appearance. At the femoral bifurcation, obviously you'll be noting the common femoral artery. Now this is what is the appearance going to look like. So the head basically is your common femoral vein. The left ear is your common femoral artery, and the right ear is your great saphenous vein. This is what you should be knowing. Okay, beta? All right, next question. What is this? This we have discussed yesterday, beta. Uh, this is a straightforward question. ये कल ही हमने discuss किया है. So I think you should be thorough with this one. What is the answer here? Mutation in PKD2 gene. Okay. Most strongly पूछा है बेटा, most strongly associated with the progression to end-stage renal disease. Okay. C. They are saying Dhanush is saying C, Arun is saying C. PKD1 is chromosome number 4. That is true. PKD1 is chromosome number 16. Okay, let's discuss this question. So, a 32-year-old man with a family history of renal failure presents with hypertension and intermittent flank pain. The accompanying renal ultrasound image is given. Genetic testing revealed a mutation on chromosome number 16. Which of the following factors is strongly associated with the progression to end-stage renal disease? तो अपन ने पढ़ा था बेटा PKD1 जो था, that was mainly associated. We read about this yesterday. कल के आप discussion में देखो, we had read about this particularly. कि PKD1 is the one that is more likely to be associated with the faster progression to end-stage renal disease. That is what is seen. So it is not PKD2. PKD2 has lesser severity. It's not female sex, it's male sex. It's not late stage, it is early stage. Which is the one that is the most important one, which can also be modified, which is the modifiable factor which can be controlled. It's the poorly controlled hypertension that is associated. What is asked? Which is associated with the progression to end-stage renal disease. So the answer is option number D. So let's quickly read about them. But PKD1 is on chromosome number 16, PKD2 is on chromosome number 4. Which is more severe? I told you it is generally the PKD1 variants which are more severe. What are the factors associated with faster progression to the end-stage renal disease? PKD1, poorly controlled hypertension, which is the major modifiable risk factor. ये आपको पता होना चाहिए, इसमें गलती मत करना बेटा, ठीक है? Male sex, large total kidney volume. If you have early onset of hypertension less than 35 years of age, if there is proteinuria and there is a recurrent gross hematuria, all of these are important factors which lead to the faster progression to the end-stage renal disease. What is this, beta? क्या है ये? Okay, so Brahmanda says it's submucosal fibrosis. Okay, what else? और कौन है बेटा? क्या लग रहा है किसी को, क्या है? बी ल्यूकोप्लाकिया. चलो बेटा, अब ये ना थोड़ा सा इसमें इन्होंने क्या किया है, इस क्वेश्चन को थोड़ा सा बेटर फ्रेम किया जा सकता था. इट शुड हैव बीन बेटर फ्रेम. So it's an ambiguous question. I'll give it to you. Those who have solved it, it is not a very well framed question. It was there in the mini test. So better would have been, this is actually the presentation. See, burning sensation, discomfort, all of these are generally the presentations of oral submucosal fibrosis. Okay, so basically submucosal fibrosis का presentation है ये. तो submucosal fibrosis का जो presentation होता है ये, this is what it is. But the SMF is generally associated with betel nut chewing. Okay, tobacco के साथ mainly association होता है, alcohol के साथ नहीं होता है. But the image again is showing you fibrous band. This is showing fibrous band. It is not showing fibrous. It's not showing a patch which is characteristic of leukoplakia. So I don't know how many of you are given the test. अगर उसमें कुछ और आंसर दिया हो तो that's okay. Don't be worried. If you're having a picture like this, leukoplakia characteristically appears as a whitish patch. This is more looking like a fibrous bands. Okay, so the answer here is going to be submucous fibrosis. Test दिया है, उसमें कुछ और आंसर दिया है. Don't worry. This is looking like, if you're asked to diagnose this image, this is going to be submucous fibrosis. This is not looking like a leukoplakia. I give it to you. Okay. All right. So Brahmana, you're right. This is submucosal fibrosis, right? अब ये वीडियो क्या था बेटा? I don't know what this question was, because what was it showing? But let me discuss the basic. Let's consider, probably it was trying to ask you about bipolar surgery. ठीक है? It was asking about bipolar surgery, because this video is not playing here for me. Based on the electrosurgical technique demonstrated in the accompanying video, which of the following? Did anyone give the test? What was it showing in the video? Because it's not playing for me. There is no video here. This is just an image which is looking like a bipolar cautery. Okay. So basically, if you're talking about the bipolar cautery, okay, this is a bipolar cautery. We are talking about the bipolar cautery. So when you're talking about bipolar, the basic pointers are, sir, it was an image only. Yeah. So let's basically discuss this from the bipolar perspective. That's what it is looking like. It's safe in the pacemakers, absolutely true. They're asking about the false statement. It is safe in the pacemakers, that is true. It provides a faster operating time, that is not true. Basically, the basic purpose of bipolar cautery is coagulation, to have a controlled surgery. Okay, that's what you use bipolar for. It is not meant to accelerate the timing. However, nowadays you have those LIGA shots, they are actually doing it very quickly. So that can be true. Those are the advanced bipolars. But if you're being asked with the conventional bipolar, it does not increase the operating time. Lower incidence of burn absolutely can be used effectively in wet surgical fields. So this is what is the benefit of bipolar, because the current is going back into the circuit, it is not being urged, so therefore it can be used in the wet surgical fields. So if it is from the perspective of bipolar cautery, if they are very clear, if they are showing you the two prongs of bipolar cautery, so bipolar monopolar identify karte aata hai na beta aapko, you'll be seeing a prong like structure wherein you are going to put it like that and coagulate. That's a bipolar cautery. In those cases, the answer is going to be B. ठीक है? Bipolar was given. Okay, fine. Bipolar cautery was given. So the answer is option number B. The faster time is not there. That is not true about bipolar cautery. Okay. Next question. ये क्या है बेटा? देखो. So let's discuss the go. जो भी आपने guess किया होगा, let's answer this question. Okay, so you're saying B, perform ad-hoc maneuver in this. Okay. So let's look at what is the condition here. A 38-year-old female presents to the casualty department with blunt trauma to the abdomen. A patient is hemodynamically stable and the senior resident decides to take the patient to the OT for exploration after initial resuscitation. You are assisting intraoperatively and find that there is a non-expanding pelvic hematoma. Okay. The pelvic viscera is grossly normal with no active bleeding. Okay, so there is a non-expanding kind of pelvic hematoma which is there. The BP is now stable. You notice a hematoma in the small bowel mesenteric border, which is also non-expanding. So दो condition है बेटा यहाँ पे. तो दोनों का management अलग अलग होगा. You have a pelvic hematoma that is a zone 3 hematoma, which is non-expanding. It's a non-expanding, yeah, it's a non-expanding one. Plus you have a mesenteric hematoma. तो दो कंडीशन है, दोनों का मैनेजमेंट अलग अलग होता है. When you talk about pelvic non-expanding hematoma, that can be conserved. You don't need to do anything about it. Okay, but whenever you're talking about the mesenteric hematoma, उसको आपको एक्सप्लोर करना पड़ेगा, क्योंकि क्या हो सकता है, there can be a tear or a cut that can be hidden beneath the mesentery, and that is where the problem is going to lie. So therefore, mesenteric hematoma you have to definitely look, but the border of the intestine has to be inspected. So what are you going to do here? You will inspect the mesenteric, explore the mesenteric border hematoma and inspect the bowel loops. So let us remember this कि फर्स्ट जोन्स आपको पता होना चाहिए, ठीक है. रेट्रोपेनिट जोन्स आपको पता होना चाहिए. कौन कौन सी जोन्स होती हैं? वी टॉक अबाउट जोन 1, दैट इज द सेंट्रल जोन, which includes the major vessels. Basically, कौन सी? Abdominal aorta, IVC, SMA, celiac, as well as the two important organs, pancreas and peritoneum and duodenum. Basically, all injuries which are happening in zone 1 have to be explored, whether it is blunt or whether it is penetrating. Zone 2 is the lateral region, that is the perirenal region, which contains the kidneys, renal vessels, and the ureters. Only if it is expanding or pulsatile, that is when we explore in blunt trauma. If it is penetrating, you have to explore. Penetrating injuries have to be usually explored. Whether it is of whichever zone, penetrating है तो आपको explore करना है. Zone 3 pelvic है, so what all are there in pelvic? You have the iliac vessels, the pelvic venous plexuses, as well as the rectum and bladder. If it is non-expanding, you will not explore. This is what is the concept behind this question. And remember, what is the thing that was they were asking about the mesenteric hematoma. Mesenteric hematoma को तो definitely आपको देखना ही है, so that there is no underlying perforation that is being hidden behind the mesenteric hematoma. ठीक है? चलो, okay. What was this, बेटा? इसका क्या मार्क किया? मेटॉक्स मैनुअल बेटा, आप ना लेफ्ट साइडेड ऑर्गन्स को आप मीडियली बेसिकली रोटेट करते हो, सो दैट यू कैन विजुअलाइज द एब्डोमिनल लोटा. इसमें आपको क्या करना है, बेसिकली हेमाटोमा है उसको एक्सप्लोर करना है. आपको एब्डोमिनल सेंट्रल जोन में इंजरी नहीं है, दैट इज बेसिकली व्हाट इज द पर्पस ऑफ. सो बेसिकली यू डू अ मीडियल विसल रोटेशन, दैट इज व्हाट इज मेटॉक्स मैनुअल. ठीक है? ओके, नेक्स्ट क्वेश्चन. ओके, बी. अरुण कुमार इज सेइंग बी. ओके. Anybody else? So let's look at this question. Regarding living donors, which of the following statements regarding organ donation are true? In adult to adult liver donor transplantation, 5 to 8 segments are transplanted. That is true. We generally prefer the segments 5 to 8. Right side ones are which are the ones that are preferred. So this is a true statement. If recipient in a child is done, if the recipient is a child, the segments 6 and 8 from an adult liver are donated. This is not true, beta. We prefer the left lateral segments. 2 and 3 are usually preferred. Okay. तो ये हो गया आपका एक सेकंड, which is not true. ये फैक्ट बेस्ड क्वेश्चन है बेटा, ये आपको पता होना चाहिए, सब फैक्ट बेस्ड चीजें हैं. In case of a GFR less than 70, kidney donation cannot be performed. This is a true statement. Generally हम जब donation की बात करते हैं तो GFR at least 80 to 90 के आसपास होनी चाहिए. GFR less than 70 is not acceptable for transplantation. If a hypertensive on ACE inhibitor and CCB wants to donate, he can donate without any problem. This would act as a method to decrease. Not true. He can donate, but this is not going to act as a method to decrease hypertension. This is not true. Person with diabetes can donate as long as GFR. No, this is not acceptable as a living donor. So what is true? Option number A and option number C are true here. So the answer is A. Next. ये question बताओ बेटा. Question number 17. बी हीमोडायलिसिस और ग्लूकोज इन्फ्यूजन। ऐसा क्यों बेटा, बाय हीमोडायलिसिस एंड ग्लूकोज इन्फ्यूजन? बी। अच्छा, व्हाट इज द रीजन व्हाई यू हैव चोजन बी एंड व्हाई नॉट ए? Stabilize the heart first. Okay. Who has answered B and why are you answering B? Tell me that. Why do you think at the potassium levels of 7.2? ओके, बी क्यों लगाया पहले ये बताओ। कोई कॉन्सेप्ट है, देयर इज अ कॉन्सेप्ट बिहाइंड इट, बट व्हाट इज द कॉन्सेप्ट? द आंसर इज नॉट बी, द आंसर is A. Let's look at the question, beta. A 58-year-old man is admitted with a potassium of 7.2 and ECG reveals only peaking of T waves, but there is no loss of T wave or broad QRS. According to the recommended guidelines, what is the next best step in management after stopping potassium intake? Agar, see, what is this? This is severe hyperkalemia. It is more than 6.5, it is severe hyperkalemia. If it had not been severe hyperkalemia and it would have been mild hyperkalemia, and then you could have had peaking of isolated peaking of T waves, then you could have avoided calcium gluconate. But this has a severe hyperkalemia. So definitely first thing you have to do is to stabilize the heart. So that is what you're going to do. So IV calcium gluconate is what you're going to do, definitely. Okay. Yeah, severe hyperkalemia hemodialysis indication. Wait. अभी पहले question solve करते हैं. Okay, let's not go into that discussion. That is medicine वाला part. Sir will anyways be covering that. Okay, but Guru sir will be covering that. So, what is the next best management after stopping the potassium intake? Potassium intake तो definitely आप रोकोगे ही. उसके बाद next best step would be to stabilize the cardiac membrane. We're dealing with a severe hyperkalemia, बेटा. Severe hyperkalemia है. तो इसीलिए irrespective of the ECG finding, you'll have to first go in and stabilize the heart membrane. That is what you're supposed to do. If it was mild hyperkalemia and isolated peaking of T waves, you could have avoided calcium salts and went on for the hemodialysis and or glucose infusion. But here you will have to stabilize the cardiac membrane. All right, next. ये क्या है बेटा? Next question. A 33-year-old man is admitted to a burn center with 30% full thickness burns after a self-immolation injury. He arrives approximately 1 hour after the injury and his body weight is estimated at 70 kgs. He has not received any intravenous fluids yet. How much fluids should he receive over the next 7 hours? इसमें दो तीन कॉन्सेप्ट्स हैं जो आपको समझने हैं. अकॉर्डिंग टू दैट यू विल हैव टू आंसर. या अब देखो इसमें क्या है. यू आर राइट धनुष. हियर व्हाट यू हैव टू डू इज फॉर दोस ऑफ यू हु आर स्टिल आंसरिंग. See, the formula wise अगर अपन calculate करते हैं, so what is the standard Parkland formula? Your Parkland formula tells you to calculate like this: 4 into 30 into 70. This is the Parkland's formula, ठीक है? But I told you that in the latest edition of ATLS and even in the 10th edition, it was updated that the revised formula calculates it as 2 now. All the adults above 14 years of age, it should be calculated as 2, not as 4. So 2 into 30 into 70. So according to the Parkland, this would have been the 4200 was your answer according to Parkland in the first video. Overall fluid आपका कितना आता है इसको calculate करोगे तो 8400 was the total. First 8 hours में आधा दे दोगे, that is 4200. This is according to the standard Parkland. But as per the new formulas, it is 2. This value is 2 now. And this is what you're supposed to use now. So what is going to be the answer here? It is going to be 2100. Okay. All right. This is what you're supposed to calculate. Yes. Okay. Next. ये क्या है बेटा? Okay, a patient is diagnosed with Stanford B aortic dissection. Stanford B है दिख रहा है आपको केवल descending aorta में ही है, so this is Stanford B. Most appropriate. So what do you do in Stanford B, beta? Basically control the heart pressure, blood pressure and heart rate. This is what is your main goals. What do? We don't go for surgery. Medical management is what is preferred in cases of Stanford B. Along with that is what we do in Stanford B. ठीक है beta? This is what we do in Stanford B. That is what is the answer here. Next question. Before that, we'll just discuss quickly. Stanford A is when you have any dissection which involves the ascending aorta. Stanford B is when only it is restricted to the descending aorta. Ascending aorta is not involved. Okay? Descending is always going to be involved. Where is the site of tear? It is present in the descending aorta. Overall, mortality-wise, which is more dangerous, is obviously the Stanford A, which is more dangerous. It has more complications and therefore it requires emergency surgery. The first choice in cases of Stanford A is emergency surgery, whereas medical management is what is preferred in cases of Stanford B. अभी अपन ने देखा, ठीक है? All right. What is the mainstay? Beta blockers are the mainstay for Stanford B. Okay. All right. Yeah. What is this? Question number 20. The accompanying video demonstrates a lower gastrointestinal endoscopic procedure. A 55-year-old patient is referred for assessment of various gastrointestinal symptoms and risk factors. Which of the following statements regarding the indications for this procedure are true? Okay, so let's look at the statements. True पूछा है बेटा. A rectal bleeding unexplained after proctoscopy or sigmoidoscopy is an indication. This is a true statement. Chronic diarrhea, that is a true statement. We have to go in when there's a rectal bleeding which is unexplained after proctoscopy or sigmoidoscopy. Chronic diarrhea of more than 6 weeks duration is an absolute indication even without prior sigmoidoscopy or rectal biopsy. No, we don't go in and do a sigmoidoscopy or colonoscopy like in this case when you have a chronic diarrhea for 6 weeks. Surveillance is recommended in patients with inflammatory bowel disease. Definitely, we do a surveillance with the help of colonoscopy in cases of inflammatory bowel disease. And this procedure is indicated for screening in patients with absolutely true. Definitely, it is definitely indicated for screening in the patients who have a family history of colorectal carcinoma. So, statements 1, 3, and 4 are correct. So, the option number A is true. Let's quickly discuss beta where all it is diagnostic and where all it is used for screening. अब जल्दी जल्दी अपन cover करते हैं इसको. We have other questions also. So in cases of rectal bleeding, it is diagnostic. In cases where there is positive fecal occult blood test, that is where it is used as a diagnostic. Whenever there is change in bowel habits, you have iron deficiency anemia, suspected colorectal cancers, and in cases of suspected IBD. सर्वेलेंस के लिए कहाँ यूज कर रहे हैं बेटा इन आईबीडी सर्वेलेंस प्रीवियस एडेनोमेटस पॉलिप्स प्रीवियस कोलोरेक्टल कैंसर्स योर लिंच एंड फैप family history of CRC, that's where we are using it. Okay, all right, next question. Colonoscopy, sigmoidoscopy में केवल आपको याद रखना है कि colonoscopy is for the entire colon where you go from rectum to cecum, right? And also we can go up till the terminal ileum. Length कितना होता है बेटा इंस्ट्रूमेंट की 160 centimeters, whereas in flexible sigmoidoscope it is 60 centimeters. This is just from the point of view if the examination is the exam asks you a particular question based on these two procedures. ठीक है, इतना ही आपको याद होना चाहिए. Next. ये क्या है? What is this? This we had discussed earlier. What is this? Question number 21. C. Yeah, so this is what is right. Dhanush, you're correct. Identify the incorrect statement about this condition shown below. What are we looking at basically? We are looking at an abdomen, a wound on the abdomen, wherein debridement is being done. Okay. So what is it looking like? This is what is your Milanese gangrene. Okay. This is what is looking like your Milanese gangrene. Okay. Now, what is true about this condition? Beta hemolytic streptococcus is the causative organism, though polymicrobial infection occurs. Yes, microaerophilic beta hemolytic streptococci is one of the most important implicated organisms for Milanese gangrene. Daily radical debridement procedures may be necessary for adequate disease control. This is the same thing. It's pretty much the same concept. If it is involving the penis, scrotum, as well as the perineal region, that's where we call it as the Fodius gangrene. If it is on the abdomen and chest wall, it is what we call as the Milanese gangrene. ठीक है, बेसिक कॉन्सेप्ट्स आपके सारे सिमिलर होते हैं मैनेजमेंट के भी, बट रिमेंबर वन थिंग हियर आल्सो वी आर गोइंग टू गो फॉर डेली डिब्राइडमेंट बिकॉज slowly the gangrene can spread further. Hyperbaric oxygen therapy definitely is going to offer some benefit. It is not a mainline treatment. No benefit is incorrect. It will offer benefit. Why it is going to offer benefit? What is the organism? It is microaerophilic. So if we give a blast of high oxygen concentration, it is going to slow down the multiplication of the organism, and therefore HBOT is therefore beneficial in cases of Milanese gangrene. So this is what is the incorrect statement. It is what represents Milanese gangrene. This is true. Okay. All right. HBO2 gives oxygen benefit. That is true. Right. Priya, you're right. Okay. Next. A 12-year-old boy is brought with the complaints of poor growth and delayed puberty. So 12-year-old boy, he has poor growth and delayed puberty. Though important आपको symptoms दे रहा है वो. He is obese and also has decreased visual acuity. On examination, visual testing is going to show you bitemporal hemianopia is there. CT scan reveals a calcified cystic mass in the suprasellar region. There is a calcified cystic mass which is seen in the suprasellar region. Which of the following is the most likely diagnosis? Yeah. Yeah, so all of you are pretty thorough with this question. It is a repeat question. The answer is craniopharyngioma. So whenever you have a calcified suprasellar mass in a young child, basically along with the presentations of delayed puberty, the child is obese, all of these are characteristic presentations of craniopharyngioma. Okay? It's a pretty straightforward question. Let's look at the important features. What is the age group wherein you're going to get wet machinery like oil will be there when you'll be operating from the cyst. That's very true. You're going to get basically a 5 to 15-year age group is seen. This is where it occurs. Location is suprasellar. Where is the origin? From the remnants of the Rathke's pouch. Imaging is going to show you calcified cystic mass. What is the visual defect that we usually see? It's the bitemporal hemianopia. Endocrine defects important है बेटा. Growth hormone deficiency होगी, there is going to be delayed puberty as well as hypopituitarism. Hypothalamic involvement की वजह से there will be obesity as well as hyperphagia. Cyst fluid आपको कैसा मिलेगा? It is going to be cholesterol rich machine-like fluid. Okay, so this was about craniopharyngioma. How will you differentiate between craniopharyngioma and pituitary adenoma? Generally, we see craniopharyngioma in children, whereas the age group for pituitary adenoma are adults. Okay. Calcification is more common. Cystic findings are more common in cases of craniopharyngioma. Origin, craniopharyngioma is from the Rathke's pouch remnant, whereas pituitary adenoma is from the adenohypophysis. Bitemporal hemianopia can be seen in both of them. Delayed puberty, again, is a feature generally seen with craniopharyngioma. And obesity, obviously, is generally that is more common with your craniopharyngiomas. Okay? All right, next question. What is this, beta? Yeah. What is this question? Question number 23. Yeah, it's a Kehr's tube, you're right. So let's look at this question. Which of the following statements regarding the instruments shown in the accompanying video are true? It is placed in the common bile duct after choledochotomy. That is true. The horizontal limb lies inside the CBD, that is true, and the vertical limb is going to drain the bile externally, that's a true statement. Patency of the CBD must be confirmed before removal of the tube, that is a true statement. You have to confirm the patency, and then only once the tract has matured, that is when you remove the T-tube. The tube can be safely removed immediately after surgery without any testing. This is not true. Immediately after surgery, you don't remove. You generally wait for 7 to 14 days for the tract to mature. That is when you finally remove the T-tube. So option A is correct. We don't use. So that is true. Option number A is the correct statement. Let's quickly look at the important pointers from this question. It is called as the Keras T-tube, generally made up out of latex or silicone, placed after cholecystectomy or when you explore the common bile duct. The horizontal limb of this device is going to lie inside the CBD, whereas the vertical limb is exteriorized for the drainage. When do you remove it? 10 to 14 days after the formation of the tract, that means post-surgery, 7 to 14 days POD, that is when you remove it. Before removal, remember, we have to do a proper T-tube cholangiogram, and the purpose is basically to decompress the entire biliary tract, drain, and therefore you can also do a post-op cholangiography with the help of, you can inject the contrast from the T-tube and do a post-op cholangiography. Okay, so that is about the T-tube that you should be knowing. ये वाला question देखो बेटा. Yeah. Okay. So this is something which is more of a question wherein which is a scoring based question. You may or may not know this. So let's read about the scores first. ठीक है, एक बार scores पढ़ लेते हैं. एक बार पढ़ लोगे तो then you'll be able to remember it better. So basically we do the Balthazar CT grading. CT हम जब कराते हैं acute pancreatitis में, so we grade it based on the Balthazar grade. So what is Balthazar grade? We call it as grade 1 when the pancreas are normal. The score allotted for that is 0. What is grade B? When there is focal or diffuse enlargement of the pancreas, we score it as 1. What is grade C? When you have, Brahmana, you're right, it is 8. The score is 8. When you have pancreatic enlargement with inflammatory changes in the peripancreatic fat, that is when we call it as grade C. So at times you can even be asked to identify which grade of Balthazar is the CT when the image is given. So they'll mention all the changes. They'll not be asking you solely based on the CT. They'll mention the changes, then they'll ask you this grading. Okay. So when there are inflammatory changes along with in the peripancreatic fat, along with the pancreatic enlargement, that is grade C. What is grade D? It is single peripancreatic fluid collection. Grade E, when you have 2 or more peripancreatic fluid collection and or gas that is seen in the adjacent to the pancreas. So what was our question saying? There were 2 peripancreatic collections which were mentioned. So that was grade E. That is the scoring for that would be 4. So ये याद रखना, यहाँ से 4 score उठाया अपन ने, ठीक है? Then necrosis score साथ में, necrosis score is going to be, if the extent of necrosis is less than equivalent to 30%, it is 2. When it is 30 to 50% of necrosis is there, it is 4. And when it is more than 50, it is 6. And that is how you add both the scores and you get your final CT severity index. ठीक है? That is called as the Balthazar CT severity index. अब देखते हैं बेटा, वापस जाके देखते हैं क्वेश्चन में क्या था. Let's look at the question from here. तो सब कुछ था, हमने देखा, CT करवाया हमने. It reveals the diffuse peripancreatic enlargement with the peripancreatic fat inflammation. 2 fluid collections were noted adjacent to the pancreas. Additionally, pancreatic necrosis था कितना? 40. तो 2 fluid collections वाला score आ गया 4. Pancreatic necrosis 30 से 50 जो था हमने उसका बोला था हमने, score कितना था बेटा? 4. So your answer is going to be 8 here. All right. Okay. Next. ये बताओ क्या है? चलो, I'll not wait for this. This is a pretty straightforward question. इसमें तो कुछ भी नहीं है, ठीक है? So, a trauma patient arrives at the emergency department after a motor vehicle collision. During the neurological assessment, patient demonstrates eye opening in response to a noxious stimulus. Painful stimulus से eye opening है, तो what is it? Spontaneous E4 to speech is E3, painful is E2, तो ये हो गया E2. Inappropriate speech क्या होता है? Confused is V4, inappropriate becomes V3. So this is V3, that is V3. Exhibits purposeful withdrawal of extremities. So basically, localizing is M5, withdrawal is M4. So this is M4. So what is your answer here? E2, V3, M4. ठीक है? By this time, you should be very thorough with the GCS scoring. GCS scoring में आप कोई wait नहीं होगा. You should be knowing. There is no excuse for not knowing the GCS scoring. ठीक है बेटा. Option D was correct. ये क्या है? Yeah, Dhanush, it is D. Okay. All right. What is this? So a term unit is born with the evisceration of bowel. Evisceration of bowel हो रहा है through a right-sided like abdominal defect. So what are we dealing with? We are dealing with a patient of a gastroschisis lateral to the intact umbilical cord. ठीक है? Okay. The exposed bowel is edematous and thickened, but it is viable. That means there is still a scope that you can save the bowel. Initial attempts at primary reduction cause rising ventilatory pressures and increased intra-abdominal tension. मतलब bowel अगर viable है तो हम attempt कर सकते हैं उसको initially reposit करने का. But if it is causing a rise in the intra-abdominal pressure and the ventilatory pressures are rising, that means what you have to do, it is edematous. Okay? You have to allow the edema to slowly subside and then you can move. So what the device is shown. ये क्या device है? पहले तो device बताओ ये क्या है बेटा? What is this device? Option B. Yeah, you're right, Dhanush. It is option B. Okay. S cannot be for omphalocele. नहीं बेटा. This is the gastroschisis का case है. This is a silistic silobags. ठीक है? That too, spring is also there and present. So basically, there are silistic silobags जिनके आसपास हम जो बॉल है इसको इससे कवर कर देते हैं. ठीक है? और थोड़ा धीरे-धीरे we gradually try to reduce the ball every day as the edema is slowly subsiding. That's when you can reposit the ball. एक साथ करने की कोशिश कर ली, नहीं हो पाया. That is when we have to bring the ball out again. हो गया. उसके बाद बॉल को साइलो से कवर कर देते हैं. It is kept moist. And slowly, as the edema reduces, that's when you'll be able to reposit the bowel. So gradual daily reduction of bowel contents is done. And then once it is done, एक बार reduce हो गई पूरी अच्छी तरह से, that is when we go for the delayed facial closure. Primary facial closure नहीं करेंगे, already आपने करके देख लिया है, so it is not going to be reattempted again. Immediate intestinal resection and stomach. Why would you resect of the intestine? It is saying it is still viable. Do you resect of the viable intestine? No, you don't go ahead with the resection of viable intestine. Topical aspirotic therapy to allow epithelialization. No, this is not going to be. So viable है. Viable intestine में कभी भी ये सब नहीं करेंगे. ठीक है? All right. Next question. Identify the incision that is shown here, बेटा. कौन सा incision है? Yeah. Anybody else? Which incision is this? Yeah, so this is your characteristic maxillectomy incision that you are looking at. This is the Weber-Ferguson incision. This is a very important question. You should be able to identify these incisions. Okay, so let's first look at where all they are used. So Weber-Ferguson is very used in cases of maxillectomy or maxillary sinus tumors. Hayes-Martin incision is used in cases of radical neck dissection. I'll be showing you all the incisions ताकि आप उनको identify कर पाओ exam में if they're asked. Blair's incision, Blair's, modified Blair's, what are they used? They're used in parotidectomy And another important one is the semengo incision that is used in cases of submandibular gland surgery. देख के बेटा identify करो. This we know. ये कौन सा incision होता है? Standard. This is your Weber-Ferguson incision. तो आपको इसमें वीडियो में दिखाया गया है. This is your Weber-Ferguson incision, right? Okay. We'll write it here, beta. This is the Weber-Ferguson incision. Okay. Next. ये कौन सा incision है बेटा? This is the Blair's incision for parodectomy. What is this one? This is the latest one that we prefer now. That is the modified Blair incision. This is the modified Blair incision. This is what we prefer for parodectomy nowadays. You can see. Okay. All right. Next. ये कौन सा incision है बेटा? This is your Hayes-Martin incision. इसकी दो limbs हैं और एक vertical, दो horizontal limb और एक vertical limb. This is the Hayes-Martin incision that is given for radical neck dissection. ठीक है? Radical neck dissection. And next is, okay, so we have come to the next question. Fine. Based on the procedure demonstrated in the attached video, which of the following best describes the tissue layers included in the harvested graft? पहली बात तो instrument क्या है बेटा? What is this instrument? और क्या निकाल रहे हैं वो? What are they taking out? Yeah. So this instrument is your dermatome. It's an electrical dermatome which is meant for taking out your split thickness skin graft. ठीक है? Split thickness graft को हम निकाल रहे हैं. तो split thickness skin graft को निकालोगे तो क्या निकालते हैं? Basically epidermis and some part of the dermis, basically papillary and plus minus some reticular dermis also can be taken. Fat कभी भी नहीं लेते क्योंकि it's poorly vascularized. You don't take a part of fat. So therefore, we take not the entire dermis, not epidermis alone. We would be needing the dermal vessels also. So we take epidermis plus some part of the dermis. That is what is your graft. Let's quickly revise the split thickness graft as well as the full thickness graft. Split thickness graft, what all do you take here? You take epidermis plus variable part of the dermis. In full thickness, you take the entire dermis. It is harvested with the help of dermatome. Full thickness generally needs a proper scalpel to take it off because full thickness of the dermis is being taken. Donor side generally heals spontaneously in split thickness, whereas a full thickness graft is going to need a proper primary closure with grafting. Okay. Graft take is better with split thickness, and which contraction is more better in primary in split thickness? It's the primary contraction which is more in full thickness. Secondary contraction is more in cases of split thickness, which has a cosmetic better result. Obviously, full thickness has better results. Where do you prefer putting it the split thickness? In cases of burns, ulcers, and larger wounds. Okay. Next question. Question number 29. Yeah, it's electric dermatome. Correct, beta. Vanilla, it is correct. Yeah. Okay, next, 29. What standard question? It has been asked multiple number of times. You should be knowing this question by now. Yeah. So a 30-year-old professional racing driver is brought to the emergency department. He's unconscious after a high-speed impact injury during a race. Initial CT is unremarkable. However, MRI reveals multiple small hemorrhagic lesions, predominantly where in the corpus callosum and dorsolateral midbrain, without any evidence of midline shift. What is the most likely diagnosis? This is a characteristic picture of diffuse axonal injury. Whenever you have a patient who is having loss of consciousness, he's unconscious, he's into coma, but the CT is not revealing any major abnormalities. MRI is going to show you problems which is mentioned here. There will be multiple small hemorrhagic lesions, predominantly where in the corpus callosum as well as in the brainstem or dorsolateral midbrain. These are the characteristic presentations of diffuse axonal injury. This is how it is going to present. ठीक है बेटा? तो ये आपको characteristic. Most important hint क्या है? Patient is unconscious, consciousness नहीं है patient की, and there is a normal CT. ये दो चीजें अगर मिल रही हैं, patient is not improving. This is pretty much confirmatory of your diffuse axonal injury. ठीक है? चलो, okay, आगे बढ़ते हैं. My friend had, okay beta, that was really sad. Yeah, great white matter junction. ठीक है, चलो. So let's quickly revise the important points about diffuse axonal injury, beta. It is a widespread traumatic shearing injury where it is occurring because of the rotational as well as your acceleration deacceleration forces at the gray white matter junction mainly. It happens at because of the high speed road traffic accidents or because of the fall from the heights as well as from sports injuries and your blast injuries. There is shearing of the axon. Because of the shearing of the axon, there is swelling in the axons. Basically, there is disconnection and you find multiple small petechial hemorrhage. That is what we see characteristically on the MRI. Hallmark presentation is what is something that you need to know. There is immediate loss of consciousness or prolonged coma out of proportion. CT में कुछ नहीं दिख रहा है. Despite of that, the patient is having an immediate loss of consciousness. ठीक है? So initially, they will always find in majority of the cases CT will be normal. Rarely at times they may also show tiny punctate hemorrhage. Investigation of choice is going to be MRI. Okay. Yeah. It will detect both the hemorrhagic as well as the non-hemorrhagic axonal lesions. What are the classical sites? This is also asked at times at the gray white matter junction. That is what was discussed in a short while from before, a short while from now. Then corpus callosum is what is the second important site, and dorsolateral rostral brainstem is the third site, which was also mentioned in our question. Beta, grading important hai. You should be knowing the grading also. Grade 1 diffuse axonal injury is when it occurs at the gray white matter junction. Grade 2 when it is also seen at corpus callosum, and grade 3 when it is also there in the brainstem. And obviously, if it has reached the brainstem, the prognosis is going to be really poor. Midline shift नहीं मिलेगा, usually absent है क्योंकि कोई space occupying lesion नहीं है, कोई blood collection नहीं है, कोई hematoma नहीं है. Pupils initially normal हो सकते हैं, but once the brainstem is involved, obviously you will have the abnormal pupillary responses. How will you manage? Management is purely going to be supportive. Neurocritical care is what you can do. Airway protection, ICP control, ventilation. Per se, कोई surgical management नहीं है. So there is no specific surgical treatment. Basically, the prognosis is going to depend upon the brainstem. अगर brainstem grade 3 है, so it is generally going to have a poor neurological outcome. ठीक है? Okay. Last question, beta. And then we'll be done for the day. From tomorrow onwards, Dr. Balu sir will be starting with medicine. So attend those sessions also. It's really important because in these examinations, we can expect them to be really clinically heavy. Okay. So 56, okay. Pooja says it is B. Okay. Correct, पूछा है बेटा. Okay. So a 56-year-old woman presents with a slowly progressive eczematous lesion over the nipple, which is associated with the erosion and crusting. So nipple के ऊपर eczematous lesion है. There is no palpable breast lump. Mammography is inconclusive. ठीक है, mammography में आपको नहीं पता चल रहा है क्या है. कोई palpable breast lump नहीं है. Which of the following statements regarding this condition is correct? Okay. So Siri, you're right, basically. So let's look at the options first. Paget's disease arises from the invasive ductal carcinoma of the nipple. No, the carcinoma will migrate to the nipple. It is arising inside into the ductal cell. It is not arising from the nipple. That is not true. So there is something called as epidermolytic migration, epidermotropic migration of the cells. बात करेंगे बेटा. So malignant cells migrate from inside onto the nipple. This is what is the accepted pathology for the Paget's disease. So it does not arise from the nipple. Paget's disease without underlying malignancy is treated by mastectomy. It is not true. जब तक आपके पास कोई lump नहीं होता है, कोई underlying malignancy नहीं है, till then we don't go for surgery like mastectomy. हम क्या करते हैं? हम core excision करते हैं. बात करेंगे. We'll be talking about the entire modules first. Let's talk about कि क्या करते हैं. अगर malignancy नहीं है तो mastectomy नहीं करेंगे. थोड़ी conservative surgery करते हैं. क्या करते हैं? बताते हैं 2 मिनट में. Triple assessment is mandatory to exclude the underlying breast malignancy. Absolutely true. क्यों? Because we know either they can be a DCIS or they can be an invasive malignancy as a underlying condition in cases of Paget's disease. Which is more common in Paget's? DCIS is more common. Invasive malignancy के chances comparatively कम. ठीक है? It never metastasizes to axillary lymph nodes is not true. It can. If there is an invasive variant, it can metastasize to the axillary lymph nodes also. So got it. So the answer is going to be option number C. ठीक है बेटा? So let's quickly look at the Paget's disease. The classical presentation is when you have a chronic unilateral eczematous nipple lesion, which is slowly destroying the nipple and it encroaches the areola also. So basically, your nipple areola complex is going to be destroyed. Remember, most important is that it can become invasive when it is having metastasis to the axillary lymph node. This is a very important point. It can metastasize to axillary lymph nodes. Histology में आपको Paget cells मिलते हैं. We already know. What is the origin? I told you underlying DCIS is the most common. It can rarely be invasive ductal carcinoma also. We accept that epidermotropic migration of the malignant ductal cells is the theory. Ductal cells se originate hota hai, then it migrates up towards the surface and involves the nipple. Triple assessment is mandatory to rule out the malignancy. And what do we assess it? We also assess the via nipple punch biopsy. If you have a normal mammogram, will it exclude the disease? No. Why? Because there can be absence of lump. If there is no lump, will the mammogram detect anything? No. If there is a palpable lump, that is more likely to have an invasive carcinoma. अब important part आता है बेटा. Let's come on to the management. Management कैसे करेंगे? If there is no underlying malignancy, very important point जो कि आपसे पूछा गया था अभी, so central core excision is done. Basically, we remove a cone of the major milk ducts along with the nipple and areola down to the pectoralis major muscle. तो cone excision करते हैं हम, mastectomy नहीं करते हैं. And this cone excision is going to be followed by radiotherapy. If there is an underlying malignancy, when you have a lump underlying malignancy hai, that is when you have to go for mastectomy, depending upon plus other lymph node involved hai, lymph node status examination. Okay? So it is not going to be mastectomy in every case. If it is without mastectomy, if it is without underlying malignancy, you will be going for central core excision. Okay? Got it? Why the answer was only triple assessment, right? Okay. So that was all, beta. These were the questions that were covered in the mini test. Please read carefully. Please have confidence on yourself. Okay, there is no point doubting yourself in this last few days. अब जो भी है, whatever time is left, one day at a time, धीरे-धीरे करके पढ़ते रहो. अच्छा, most important is whichever is your weak area. Okay, ठीक है. कोई एक चीज छूट भी गई, आप 2-3 टॉपिक छूट गए, कोई फर्क नहीं पड़ता. प्रॉपरली कोई वीक एरिया है जिसमें हर जीटी में आपको पता था कि मेरे से 15-20%, 40% के आसपास जो है गलत होते जा रहे हैं क्वेश्चंस. दैट इज वेयर यू नीड टू रियली स्टार्ट फोकसिंग. दोज आर द एरियाज व्हिच यू रियली नीड टू फोकस राइट नाउ, नॉट इन द लास्ट 2 वीक्स बिफोर द एग्जामिनेशन. ठीक है, तो अपना टाइमर सेट कर लो कि मुझे अगले 10 दिन के अंदर अंदर, द नेक्स्ट 10 days, whichever are my weakest areas, which I know I'll definitely get the questions wrong, those have to be sorted first by all means. Then you can move on to the areas which are comparatively easier for you to remember. ठीक है, तो पहले weaknesses को तो मिटाना ही है, ऐसा नहीं करना है कि उसको छोड़ दिया एंड that is what is a big mistake that most of the students make. ठीक है, तो सीक्वेंस में चीजें लेनी है. तो अभी तक आप जीटी देते आ रहे हो, आपको समझ में आ चुका होगा by now which are the areas which are really weak. Focus on those areas. स्मार्ट स्टडी करनी है अभी आखिरी टाइम में. ऐसे नहीं फिर से वापस उठा के बैठ गए, फिर से पूरे 20 सब्जेक्ट तुमने सब्जेक्ट वैसे ही पढ़ रहे हो जैसे पढ़ते थे शुरू में. नो, ओनली द एरियाज वेयर यू आर वीक and you are repeatedly getting the questions wrong, that is what you need to mainly revise. Got the point? Any doubts you have, you can text me. I've told you, surgeontalkies@gmail.com. You can drop a text in the comment sections here. I'll get back to you. और अपडेटेड बेटा जो भी अपडेट्स हैं, I'll try to make a PDF. जो चीजें हैं वो I'll try to make if possible and I'll give it on the Telegram channel. ठीक है बेटा? Okay. All the best. Read well. And I hope you'll be having a wonderful exam. Thank you so much.